Thank you very much for coming to our seminar, luncheon seminar today. This seminar will be chaired by Dr. Kohno and sponsored by Inocras and Summit Pharmaceuticals International Corporation. We have the questionnaire included in our package. So at the end of the talk, we ask that you fill in the questionnaire and hand over to our staff. Thank you. So Dr. Kohno, could you start, please?
Thank you very much. And welcome to this luncheon seminar by Inocras Corporation. I am Takashi Kohno of National Cancer Center and also an organizer of this international symposium. And this session's name is, please show this is the title of this session is The Era of Routine Cancer Whole-Genome Examination using FFPE samples, Insights from Japanese Patient Data. And as you may know that Japan as a nation have an initiative to implement whole genome sequencing for cancer genomics, cancer diagnostics. And usually we basic scientists use frozen sample tissue for the whole genome sequencing analysis. But of course, in the clinical setting, as in the case of gene panel test, FFPE samples are more and more appropriate and very convenient for the diagnosis. And so, in this session, we will focus on the whole genome sequencing analysis using FFPE samples. And today we have two speakers. And one is Dr. Hiroyuki Fujii of National Cancer Center, and the other is Dr. Youngseok Ju. He is a co-founder of Inocras Corporation. First, I'd like to introduce Dr. Hiroyuki Fujii by myself. And he graduated from Faculty of Medicine of Kyoto Prefectural University of Medicine. And so his specialty is respiratory medicine.
Yeah.
Yes. But now he is in National Cancer Center, and our National Cancer Center have a project of whole genome sequencing, and for the implementation of this method is organized by many physicians, like Dr. Tsunami, she is present there, and also Dr. Hiroyuki Fujii is like a top leader and a top scientist of our whole genome sequence project or in National Cancer Center. So could you please start your presentation?
Sure. Thank you for the kind introduction, Dr. Kohno. And hi, good afternoon, everyone, and welcome to Kyoto. I'm Hiroyuki Fujii from National Cancer Center Hospital. And as already Dr. Kohno mentioned, I graduated from Kyoto Prefecture University of Medicine, and I'm a member of Department of Pulmonary Medicine. So Kyoto is a very special place for me. So I'm very, very glad to see you all here in Kyoto. So today I have only 15 minutes, so let's move on to the topic. And this session was supported by Inocras and SPI, so I would like to express my gratitude to them for giving me a chance to present it here. And I have no words to disclose. So these are today's agenda. At first, I would like to briefly introduce a national project of whole genome sequencing implementation. And after that, I want to introduce the WGS Nobel platform using FFPE sample developed by Inocras. The platform name is Cancer Vision. And after that, I would like to share our own experience using Cancer Vision at our cancer center. So now Japanese government launched project for clinical implementation of WGS, and the plan name is Action Plan for Whole Genome Analysis 2022. And this figure shows the missions and visions of this project. This project has multiple dimensions. First, patient benefit and data accumulation and research and drug discovery. This project has multiple dimensions. And also, it is a provisional version. The guidance on specimen handling for cancer whole genome analysis is already presented to us. And the guidance says the principle is to use fresh frozen tissue samples. But however, as you know, this method is challenging to perform under daily practice because labor-intensive process or time limitation. And the biggest problem is only with prospectively collected samples. So on the other hand, how about FFPE samples? FFPE is familiar and easy to handle in clinical practice, and testing is possible using archived specimens. So WGS using FFPE sample is anticipated. So what are the barriers to whole genome sequencing using FFPE samples? One of the answers is DNA quality for WGS. This figure shows a circus plot and depth distribution plot for fresh frozen and FFPE sample. As you can see, the circus plot in the FFPE, there is some changes which appear some noise, and the depth distribution is more scattered than the fresh frozen. So challenges with FFPE sample for WGS is as follows. DNA is often damaged and contains high background noise, and conventional methods often fail to extract WGS quality DNA. And even if DNA is obtained, analysis is frequently difficult. However, Inocras developed a machine learning-based digital solution to correct DNA damage from FFPE samples. By adopting this digital solution, the scattered depth distribution became more uniform, and it is easy to analyze this. Because I'm just a single user, I'm not good at this Inocras own techniques. So if you are interested in, please ask Dr. Ju. So the novel platform with this fine solution and developed by Inocras is Cancer Vision. So Cancer Vision is a somatic plus germline paired test, such as NCC OncoPanel. And this Cancer Vision can detect complex somatic variants and genome-wide mutational patterns and germline variant. And as of today, this Cancer Vision is provided in Inocras ClearCap Labo in San Diego only, and turnaround time is almost 14 days. And the biggest feature of Cancer Vision, one is already I mentioned FFP correction technology, and the another point I would like to highlight is target-enhanced WGS system. So what is this? So target-enhanced WGS is the combination of TPS and WGS. TPS means target gene panel sequence. Maybe you are familiar with the CGP in Japan. And WGS, as the name of WGS suggests, WGS can analyze whole genome regions. However, the weak point, because of the relatively depth is shallow than the TPS, there is a potential risk of missing an important variant for WGS. However, Cancer Vision and Inocras effectively reduce that risk by adding TPS on WGS. So actually, Cancer Vision's whole genome sequencing depth is only 40. However, TPS in Cancer Vision covers more than 600 genes. So this is a great solution for WGS with using FFP sample, I think. And after that, I would like to share our own experience using cancer vision for 20 samples from our cancer center. This left figure pie chart shows the breakdown of cancer type. And the most common one was ovary cancer, which reflect our interest in MSI high cases. And there were some case of soft tissue samples, soft tissue tumors, because we want to know how well the structure variant can be detected by this cancer vision. And these 20 samples included 3 cases, previously failed FFPE-based whole genome sequencing by as a conventional method. And they are all soft tissue tumors. And the right figure shows the time from sample collection to DNA extraction. Almost half the cases is the less than 1 year old specimen. However, the longest interval was 40.8 years. And this cancer was gastric cancer. Even using such old specimen, cancer vision can analyze successfully with FFP samples. And this slide summarizes the information on sample quality and sequencing depth. And this orange row shows the QC cutoff and depth lower limit for each sequencing. And the central green column shows the tumor sequencing depth by WGS. So the depth lower limit for tumor sequencing by WGS is 30. And as you can see, all tumor samples reach the target depth for WGS. Next, I would like to introduce the design and the unique features of cancer vision report from a clinical perspective, because I'm a respiratory physician and medical oncologist. So at the top of the first page, you can find the summary of information related to the treatment. I think this is extremely important thing for clinical physicians, because what the clinician care about most is what or which therapy can be offered to the patient sitting in front of us. So easy to understand and simple style is very important for the busy clinician, I think. In this ovarian cancer patient had the germline pathogenic BRCA1 variant L63 termination, which is very popular in Japan. So the some PERP inhibitors are recommended in this report. And because this cancer vision is USA-based examination, the evidence level is slightly different those which used in CCAT in Japan. And further details, including clinical trials, are present in the following page like this. There is very detailed information in the page. And next, the report moved to the germline variant and genomic instability information. Genomic instability information includes the TMB and MSI and HRD status. And these data are visualized with this bar scale, so it is very easy to understand. And this patient I already mentioned, she has the germline BRCA1 variant. The HRD score was positive. And in the D section, detected somatic driver alternation is described in details such as like this. And in the case of structure variant, the report tells us which intron or exon contains a breakpoint. So it is very useful for interpretation. This structure variant is pathogenic or not pathogenic. So it is very useful for the clinician. And you can access the result not only through the report, but also via an advanced genomic viewer for visual exploration. And this viewer is very user-friendly. It is very easy to control, and it is very sophisticated. It's a screenshot of this viewer, and this is a sample of TP53 splice site variant. You can see this pin. This pin means where is this variant exists. You can understand easily this variant is located in between exon 3 and exon 4. So the location of the mutation within the gene region is easy to identify. And by visualizing the status of each allele and red or blue lines, the presence of LH become more clearer. So the cancer vision can detect and teach and visualize unique insights unlocked by only WGS. So such as a signature over circus plot. And in this case, cancer vision detected SBS3 signature, which related in HRD signature. So as already I mentioned, this patient has a BRCA1 variant. I think it's a correct answer for signature, I think. And I want to introduce a case which could not be analyzed using conventional method. Looking at the circus plot, the previous failed cases indeed have extensive DNA damage and a high level of background noise. However, cancer vision successfully performed analysis on cases that had previously failed using conventional method with FFPE. And while, of course, Inocras solution is major step forward, however, clinicians also need to provide better quality FFP samples for WGS. I will skip the detection technical details because this is under investigation. But please take a look at two circus plots. The left shows a sample fixed with our routine method, but there is a high noise. The right used a single modifier fixation method, and the noise is clearly reduced. So this highlights the importance of collaboration from the clinician side as well. We need to further explore optimal FFP processing condition to reliable WGS analysis. So this is a summary slide of my presentation. So please remember the name of cancer vision and the target enhanced WGS system. Thank you very much.
Thank you very much. So we will take questions after Dr. Ju's talk. So let's move on to the next speaker, Dr. Youngseok Ju. He is a co-founder of Inocras Corporation, and he is very famous for the whole genome sequencing analysis for genome research scientist. So he first published whole genome sequencing result in Nature 2009. He completed the genome sequencing of Korean individual. And after that, he found red fusion by using whole genome sequencing. Red fusion was discovered by 4 groups simultaneously. One of the groups was my group, but anyway, he found red fusion by using whole genome sequencing in 2011. At the time, he's really a pioneer of whole genome sequencing. So let's start your presentation.
Thank you very much, Dr. Kohno, for providing me the opportunity to speak. So today, I'd like to talk about our recent data. Thank you. So whole genome sequencing of around 1,300 breast cancers with clinical outcomes. So I'm a co-founder of Inocras. And Inocras is a 5-year-old company. We started from Daejeon, Korea, but we have now 3 offices, one in Korea, San Diego, and Hong Kong. Headquarters is based in Hong Kong. And as Dr. Fujii introduced, we are providing target enhanced whole genome sequencing. It is a clinical grade whole genome sequencing, and our outcome can be used for diagnostics in Korea, in the US, in Hong Kong, not in Japan yet. So we guarantee maximum 14 days of turnaround time, and we analyze tumor and normal whole genome sequencing and targeted panel sequence CGP, and we provide our report in 14 days. And also, there is the paper report we provide paper report and the genome browser for tumor board for research. And also, we do patient service for clinical trial matching and genetic counseling sometimes. For the last 5 years, using our the Cancer Vision product, we have conducted many collaboration studies with the hospitals. So far, we sequenced around 13,000 whole genomes of tumors, and we put the genome sequences with real-world clinical data. So today, I'd like to talk about the first study, which will be published very soon. So this is a Kubrick's cohort. We sequenced 1364 breast cancers. And we combine, we have a whole genome sequencing of all tumors. And also we combine 1,200 whole transcriptomes. And most importantly, full medical histories are combined. So this is under revision, and the genome data is already available in public. So if you go to the open.cancervision.com, then you can browse all the patient whole genomes. So this is the database. If you get there, there are 1,300 breast tumor lists, and if you click, then you can browse the whole genome sequences. So this is I'd like to talk about what we learned from the 1,300 breast cancer genomes. This is a landscape of somatic mutations in 1,364 breast cancer. It's too complicated. If we make it a little bit simpler, we identified 41 point driver mutations. But many of them are already discovered in the previous cohort. But there are 6 novel driver genes as well. For example, BCL11B, RREB1. So they are recurrent in 20-something patients. So these genes should be new driver mutations. Using whole genome sequencing, we can easily calculate the intratumoral heterogeneity score, or MES score. So using the variant allele fraction of there's many variants in the genome. And the MES score distribution is associated with TP53, but the MES score is associated with poor patient outcome. It is an independent the factor for prognostic the factor in breast tumors. So MES score was also associated with first-line anti-HER2 therapy. So the tumors with high MES scores showed the poor the progression-free survival in HER2 breast cancers until the first-line anti-HER2 therapy. From whole genome sequencing, we can easily calculate the mutation signatures. And for example, these are the mutation signature 5, 313. These are clone-like mutation signature, HRD, ApoBec, and so on. But there are some rare mutation signature found in our cohort. So these are 4 breast cancers with very rare mutation signatures. They are the hypermutators mostly. So usually in breast cancers, we find 10,000 the mutations genome-wide. But here we find 300,000 mutations, 30 times higher mutation burden than usual breast tumors. So these are 4 the mutators, breast cancers, and very rare mutation signature. We can easily calculate homologous recombination deficiency, or HRD. So usually in the clinic, myriad test is sometimes necessary, but whole genome sequencing already include that module. So with a cutoff of 0.2, we find around 23% of their breast tumors are HRD, and they are niche and basal, the breast cancer type. And we also provide a germline and then somatic mutation profile, and we can reveal some germline reason, underlying reason, and somatic underlying reason for HRD in breast tumors. But still, many of the tumors with HRD still lack some the mutation, germline or somatic mutations. This is one case. So this is the HRD case, but was not detected in the clinical testing. But cancer vision, we can detect this HRD case. And interestingly, we found the RAD51C gene in germline and somatic sequences. So it is the RAD51C germline HRD case. And after our testing, the clinician can use talazoparib, and it was working. So it was a good for the patient, for patient clinic. HRD was a predictive biomarker for the adjuvant anthracycline cyclophosphamide therapy in TNBC. So as you can see here, the HRD tumors showed better the disease-free survival in adjuvant anthracycline cyclophosphamide TNBC therapy. Also, HRD was the biomarker for CDK4/6 inhibitor plus endocrine therapy in hormone-positive breast cancers. So here, HRD tumors showed poor the outcome in the CDK4/6 inhibitor therapy. Structural variation is another one we can do from whole genome sequencing. So we detected more than 100,000 of structural variation in the genome. Most of them should be a passenger mutation, but some of them are the driver. And we were interested in the recurrent fusion genes, for example, MIPOL1 TTC6 or BCL2L14 ETV6. Those are the recurrent fusion genes in our cohort. And also an ESR1 fusion gene as well. And also, NRG1 fusion gene was quite frequent in our cohort. The prevalence was 1.5%, identified in 17 cases, but its fusion partner was quite various in this case. And interestingly, in NRG1 part, all the fusion genes retained EGF and neuregulin domains. So it ensures that the fusion genes should be functional. Focal amplifications, for example, this is one case of focal amplification in chromosome 17. So the other regions are copy number 2, but HER2 region is amplified into 200 copies. This is an abrupt the increase in copy number. And in the 1,300 whole genomes, there are 3 focal amplification hotspots. One is in chromosome the 8, 11, and 17, where the FGFR1, ZNF703, and CCND1 ERBB2 genes are located. And interestingly, the HER2 focal amplification is a biomarker for the neoadjuvant TCHP therapy in HER2 breast cancers. In the clinic, immunohistochemistry is one method to screen out the patient. It is good. It is very sensitive, but there are many false positives. Some patients are not the therapy is not working for the patient. If we add HER2 copy number, this is a more specific marker for the therapy. So if we add those two things, the F1 score is increasing. Large segmental amplifications, this is a broad level amplification. We find many structural variations genome-wide, which are very frequent in breast tumors. And we can understand the timing of acquisition using whole genome sequencing. And many of the mutations were acquired in 0.1 in the molecular age, that is very early puberty. Anyway, in terms of for the clinic, chromosome 9p amplification was very interesting because 9p23 was the independent prognostic biomarker in basal-like breast cancer. So tumors with 9p23 amplification showed poorer the survival, but we don't know the underlying mechanism. So to wrap up, so this is the most comprehensive whole genome sequencing analysis in breast cancer so far, and we expanded the repertoire of oncogenic alterations, and there are many prognostic biomarkers not previously identified because whole genome sequencing was not available before. So these include SV copy number and signature pattern-based genomic biomarkers and so on. Again, this is under review and the genome data is available in public. Thank you very much for your time. Lastly, we are working with SPI in Japan, and we are here for collaboration studies and for diagnosis in the clinic. And please contact us if you need any help. Thank you very much for your attention.
Thank you very much for nice talk. Youngseok, could you have some comment on the, for example, like approval or application status in the US?
Yeah, so our test Cancer Vision is under Medicare coverage the application now. So we applied our Cancer Vision last February, and we are under revision at the moment, and we will submit our revised application by August. And we believe by end of this year, we can get the Medicare coverage of Cancer Vision in the US. That means it will be covered by Medicare. Yeah, thank you.
Thank you so much. And now that this Cancer Vision is tried by several academias, including us and also Dr. Kage's group. Dr. Kage, do you have some comment or the impression using a Cancer Vision test in your sample?
Sorry. Thank you for the question, Dr. Kohno. So we analyzed the 10 lung cancer samples and compared the CGP testing with Cancer Vision, and we also, as Dr. Fujii mentioned, we also got very good results as well. Thank you.
Thank you.
I'm
very
so
happy
much.
with that. Yeah.
So we have a little bit time to take some questions for both speakers. Do you have some comment or questions from the audience? No questions? Yes. So thank you very much for Dr. Ju and Dr. Fujii. Thank you very much.